Hello and welcome to our public health webinar. My name is Imad Maswadi. I'm Assistant Professor of Biostatistics at Institute of Public Health at College of Medicine and Health Sciences, United Arab Emirates University. We are proud to be affiliated with ASPHERE, Association of Schools of Public Health in European Region, and IFA, the Emirates Public Health Association. This webinar is a part of a global campaign under the name This is Public Health. We are organizing our webinars monthly with the aim of highlighting different important public health issues. Our webinar is accredited by UAE University as 1 CME. In this webinar, you will be able to ask questions. You can do so by clicking on the Q&A option in the middle bottom of the screen. You can submit your questions during the presentation, and you will cover them at the end of the presentation. This webinar is recorded, and the recording will be uploaded to our YouTube channel, Institute of Public Health-CMSHS, where you can find recording of all previous webinars hosted by the IPH. At the end of the webinar, we will share a link in the chat for the evaluation of the webinar. You need to fill the evaluation to obtain your certificate. Now, allow me to introduce our speaker. We are really honored that our invitation was accepted by Dr. Stephanie Thomas. Dr. Stephanie Thomas has been a consultant medical microbiologist at Manchester University Foundation Trust, Whitenshaw Hospital since 2010, and is currently the head service of Manchester Medical Microbiology Partnership. She gained an oral degree in biochemistry with microbiology from St Andrew University, Scotland, and her medical degree from Dundee University. She completed higher specialist training in medical microbiology in Manchester, UK. During the time, she completed a master's degree in diagnostic and medical virology at the University of Manchester and a diploma in tropical medicine and hygiene at the Liverpool School of Tropical Medicine. She holds also a postgrad certificate in the medical education. In 2017, Dr. Thomas undertook an observership program at WHO UNCT of Copenhagen with the European Society for Clinical Microbiology and Infectious Diseases. And for the past year has been on sabbatical in the Laboratory on Testing Cell of Public Health Scotland, PHS, working on the COVID-19 response. During this placement, she was the COVID-19 testing lead for the Climate Change Conference COP26, held in Glasgow, Scotland. She has recently been appointed in the role of Adjunct Assistant Professor at the Institute of Public Health. Dr. Thomas has published widely in peer journals and been invited as speaker at scientific conference nationally as well as internationally. She has contributed to textbook chapters on infection and prevention, and infection in critical care patients. The title of this or her talk today is about the climate change and its implication for infectious disease epidemiology. Dr. Stephanie, the virtual floor is yours now.
Thank you very much, Dr. Ahmad, and thank you to Professor Gribner and to Professor Sheikh Mohammed and everyone at the Institute of Public Health for the very kind invitation to speak here this evening. It's my very great pleasure to introduce my presentation. And so just really to start with a background to my interest area and why I have this interest area. As Professor Ahmad very kindly presented in April of 2021 to 2022, I undertook a sabbatical post funded by the UK government out of the COVID monies to work within the laboratory and testing cell with Public Health Scotland, a national public health body in the United Kingdom. And I was asked to be the testing lead for COP26, the climate change conference that was held in Glasgow. And we were asked as part of a team to prepare and provide a robust, streamlined COVID-19 testing and reporting system for all of the delegates and all of the staff. And this in the background here, you can see this is where COP26 was held at the Science Centre in Glasgow in Scotland. And so welcome to COP26. COP26 stands for Conference of the Parties, and this was the 26th conference that had been held, and it was in November in Glasgow in the winter. The conference itself, COP, is owned by the United Nations, but this COP was organised by the COP26 unit of the United Kingdom government. The key task of COP was to review national communications and emission inventories and to assess effects of measures set out by the Paris Agreement and the UN Framework Convention on Climate Change. This was a multinational event. It was the largest summit that the UK had ever hosted, and it was held in the middle of a global pandemic. And of course, fortunately, this is not taking place within a global pandemic, but of course you may well have other issues with infectious diseases purely because of the number of delegates that you may see coming into and out of Dubai in November. So the PHS legacy, really the legacy action from COP26 for Public Health Scotland was the science behind the conference. It wasn't really the COVID testing. In Scotland, we know that climate change is already impacting the country with warmer temperatures and wetter weather. And we know that this will impact on the population's health, and it's being actively considered by Public Health Scotland as we speak. And we are aware that it's a complex area and it requires cross-cutting collaboration across many, many organisations. There is a climate change committee within Scotland, which is an independent body who will advise the United Kingdom's and the devolved governments on the progress being made in preparing for and adapting to the impacts of global climate change. And this committee has identified 3 priorities with regards to climate change and health, and they are specifically resilience of the population to changes in temperature, resilience of the people to pathogens, potentially new pathogens seen with climate change, and the changes in air quality. And in a report released in March 22, it notes that the availability of data to measure the level of risks remains limited, but really is one of the key areas in public health. And as we all know in the field of public health, you can live or die by the quality of your data, and high quality, robust data really does feed many, many of the public health actions that we all work with. And so for the next part of my presentation, I'd like to concentrate really on this article, which is a recently published article from the Infectious Diseases Society of America, the IDSA, published in 2022, entitled Climate Change and the Epidemiology of Infectious Diseases in the United States. Now, it is from the United States, but really we can all take example from this paper. The conclusion says that changes in the prevalence of infectious diseases not only reflect the impacts of temperature, humidity, and other weather-related phenomena on pathogens, vectors, and animal hosts, but are also part of a complex social and environmental factors that will be affected by climate change, including land use, migration, and vector control. Vector and waterborne diseases and fungal diseases such as coccidiomycosis are all likely to be affected, probably increased, by a warming planet. There's also potential for climate-driven impacts on emergency infectious diseases and, interestingly, on antimicrobial resistance prevalence. Additional resources for surveillance and public health activities are urgently needed, as well as systematic education of clinicians on the health impacts of climate change. So it's a really important paper and it packs quite a punch. So, climate change and its impacts on infectious disease epidemiology. Climate change is altering the planet. We have accepted that. In 2020, the global surface temperature was 2.14 degrees Fahrenheit, warmer than during the pre-industrial period. We have seen the 10 warmest years on record since 2005, and in North America, a rising surface temperature has led to a decreased snowpack and seasonal runoff from the mountains, glacial retreat, sea ice reduction, severe weather and flooding, droughts in western and central plain regions, sea level rise and acidification of coastal waters. And these changes have degraded marine, freshwater and terrestrial ecosystems, has impaired freshwater resources and caused damage to infrastructure, livelihoods and well-being. And this was taken from Sky News one day ago, and this is New Zealand in January. And this report notes that a New Zealand bound plane flies 13 hours only to land back in Dubai after an Auckland floods have closed the airport. And if you think about what is floating in and around that water, I can put money on there being a high prevalence of some form of infectious disease, possibly enteric related. Changing weather patterns will have profound impacts on food and national security, physical and mental health, and, which is what we're interested in, the epidemiology of infectious disease. Global warming is leading to changes in the density and range of vector populations, as well as the migration patterns of animals and birds. Very important if you have your One Health hat on. Avian influenza in waterfowl and shorebirds, Lyme disease and West Nile virus have all been shown to be spread by migratory animals. So the more these animals need to move because of climate change, the more risk there is for these infectious diseases to move north or south wherever they shouldn't be. Changes in ecosystems from drought, fires and other extreme weather may force animal species and humans into closer proximity, and changes in the incidence of human and animal diseases may be an early sign that geographical ranges of intermediary hosts and vector species are evolving. Again, it's down to that data and using data as an early warning sign. This, if you can believe it, was in London in the summer of last year. We saw for the first time on record temperatures of 40 degrees, and there were outbursts of sporadic fires in and around dry and grassy areas in London, which is our capital, and there was a huge need for firefighters in and around that day, and I most certainly remember it being incredibly hot. And of course, in the United Kingdom, we are definitely not geared up for temperatures like this. Climate-related migration of human populations can also drive susceptible people into areas with endemic disease and push those infections into areas where the diseases are not present. And there's a very nice example of this in this paper from 22, from the IDSA paper, which notes that the impact of large-scale human migration prompted by severe economic and political dislocation can be seen in the recent experience where malaria amongst Venezuelan refugees was seen in Colombia. In the United Kingdom, we are seeing an increase in cases of diphtheria, for example, in refugees coming in from Ukraine. And so climate change driven extreme weather events will also have very direct impact on infectious diseases by certain mechanisms, for example, dispersion and optimization. So in terms of dispersion, this is dispersion of pathogens far more easily than they would have, say, 50, 100 years ago. As we've just seen with those flooding, if you have flooding in and around a house, then there will be enteric pathogens in and around carpets or floors, which may well therefore lead to an increased numbers of gastroenteric illness, certainly if there are children in the dwellings. Fungi, if you have increasing drought or changing wind patterns and increasing sandstorms, which potentially is relevant for the UAE and the area of the Middle East, you then potentially get more whipping up of these sandstorms and movement of fungi. We have seen an increase in meningococcal disease, for example, recently, which we think is secondary to the countries coming out of lockdown and coming out of the pandemic. But we do know that meningococcal disease is associated with sandstorms and the fact that the sandstorms can damage mucosa, letting these bacteria in. So are we at risk of increased meningococcal outbreaks with increased sandstorms? Optimizing conditions, of course, changes in sea surface temperature and salinity potentially can allow for the expansion of the Vibrio species. foodborne illness due to the fact that we're not refrigerating our food adequately because the temperatures are too high, particularly important in northern countries where we're just not used to these temperatures, for example. And septicemia due to very high temperatures, potentially amongst elderly, immunosuppressed patients who get very dehydrated and then end up with urinary tract infections leading to sepsis. And this is really just a pictogram of all of these extreme weather events, human migration, changes in animal and vector ecology, rising temperatures, changes in water quality and quantity, leading to so many diseases that yes, we know about and yes, we see, but there is the risk for an increase in numbers of these and a change in the epidemiology in terms of where we see them. So to understand the complex interplay amongst the changing climate, land use, human and animal migration, environmental impacts and disease epidemiology, we need surveillance and we need environmental monitoring. And to do this on this One Health basis is so very, very important. So One Health is using a collaborative, multi-sectoral and transdisciplinary approach, working at the local, regional, national and global levels with the goal of achieving optimal health outcomes, recognising the interconnection between people, animals, plants and their shared environment, and offers a framework to adapt to changing environmental, social, development and health-related terrains. It's this link between humans and animals and what comes in between. One Health. And if anybody is particularly interested in reading more about One Health, The Lancet has this month, January 23, published a series all around One Health and global health security, and it's an interesting read. So starting then to talk about some specific infections associated with global warming and climate change, and starting with vector-borne infections. Changes in the average temperature in the United States, they think, could result in the introduction of new vector-borne diseases and increases in the incidence of endemic diseases. Now we know that the rapidity of which mosquitoes can extend their ranges once the environment is right. And with this, we may well be seeing mosquito-borne and tick-borne diseases in places that we didn't see it before, in environments that are not used to it, in medical conditions that are not ready to diagnose it. Gradual northern spread of the Ixodes scapularis tick in the United States and Canada has taken place, and the Canadians do feel that global warming may well have been a very key factor in this spread. And then moving on to waterborne diseases, we've touched on it a little bit already. In the United States, the principal bacterial diarrheal diseases, which is probably the same for most countries, certainly the same for the United Kingdom, Salmonellosis, Shigellosis, Campylobacter, E. coli and Yersiniosis, and we are seeing an upsurgence definitely of Yersinia, and we're not entirely sure why, and the UK Health Security Agency is looking into that in the United Kingdom, as well of course viral diseases such as norovirus and rotavirus. Generally spread through contaminated food and water, and person-to-person spread because of unhygienic practices, but of course these organisms are sensitive to climate warming, and again, if you have flooding from extreme precipitation, flooding can contaminate water supplies with animal waste, leading to outbreaks of waterborne infections that cannot be put down to fecal-oral spread and poor personal or hand hygiene. Severe storms can also cause overflow in wastewater, threatening the drinking water supplies. An example of this was an E. coli gastroenteric outbreak in Ontario in Canada in May of 2000. And heavy rainwater runoff has been associated with outbreaks of giardiasis in Montana, with cryptosporidiosis in Milwaukee, and E. coli and Campylobacter in New York at a state fairground. So we are seeing this. And then moving on to airborne infections, coccidiomycosis, the desert pathogen. It's long been noted that a period of high rainfall, presumably promoting soil hyphae growth, followed by a dry period, which increases the risk of dust storms with aerosolization of your arthroconidia, leads to an increased disease incidence. And coccidiomycosis has also been identified in more northern areas in the last 2 decades, including northern Utah and eastern Washington state. Conditions that promote the growth of coccidiomycoses and aid the dispersal are likely to be more common in North America as the earth heats. And I suppose the question again for any desert or arid area is this the same for you? And then moving on to emerging infectious diseases as a category in itself. And we have all just lived through the challenge of the COVID-19 pandemic, the global pandemic. And while the origin of SARS is under investigation, the presumed transmission from humans to humans from bat species through an intermediary host is thought to be the way that this global pandemic began. This would be the third such spillover of an animal coronavirus to humans in the last 2 decades. Now, what I don't know is that normal, or is that higher than normal? It certainly seems higher than normal, but of course we don't have the data from the last 100 to 200 years. So what we now know is that with SARS and of course MERS from camels, we now have COVID-19 from bats. That's the third of these human to animal spillover infections. Climate change may be a driver of these spillover events by altering the habitats and pushing the geographical distribution of animal and human populations into closer proximity. As the world changes, we move closer together, as well as creating ecological and evolutionary pressures that lead to genetic changes in pathogens that may affect the fitness of animal to human transmission. Are we just making it easier for this transmission and this cross-species infection to happen? An example given in the paper is Hendra virus, which is similar to Nipah virus, a bat-borne virus, associated with spillover events into horses and humans. Case fatality rate of 50 to 75%. Models suggest that under the pressure of climate change, the geographic range of risk and the risk to humans of spillovers will expand. The risk of emergence and re-emergence of infections from animal hosts to human populations necessitates increased surveillance and modelling of the influences of climate change on animal behaviours, breeding, migration, pathogen shedding. It's all about the data, and so within this era of climate change, it's all about surveillance and modelling for what we should be expecting in the future. And then finally, antimicrobial resistance. There is evidence that links global temperature changes to expanding antimicrobial resistance. Immediate temperature surroundings of a bacteria directly affects bacterial growth, survival and adaptation. Temperature trends in local geographical areas, in addition to selective pressure from antibiotics, have been associated with a change in and increase in antimicrobial resistance. This paper, again noted in the 2020 IDSA paper, found that a 10-degree Celsius difference in temperature across the regions of the United States was associated with increases in antibiotic resistance of 4.2% for E. coli, 2.2% for Klebsiella pneumoniae, and 2.7% for Staphylococcus aureus. Subsequent ecological study replicated these results across Europe and found that the rates of antibiotic resistance correlated with ambient temperature. Climate change may also affect fungal evolution, as we've seen with the coccidiomycosis, for example, including contributing to the thermal tolerance that potentially led to the expansion of Candida auris into the human population. And we have definitely seen outbreaks in our intensive care units in the United Kingdom of Candida auris recently. And nobody really knows where it came from or why the increased incidence. Antifungal resistance was already in existence at this time when this organism was first identified, and this suggests that efforts to manage the public health concern of antimicrobial resistance, and there is a huge focus on AMR and managing AMR, particularly as we're coming out of COVID, where we know that many people were given antimicrobial prescriptions that potentially they wouldn't have done or didn't need just because these patients were so sick with COVID. But we may now need to include and incorporate climate factors into our drive to reduce AMR. So, future surveillance and disease control activity. The urgency of the global response to climate warming has been highlighted by scientists, by clinicians and public health experts who continue to identify and investigate climate-related threats to death. Surveillance of the effects of climate change will, to a large degree, be reflected in the work of public health agencies and the work that they do every day in tracking diseases. So we monitor the background prevalence of infectious diseases and infectious pathogens, and we look for exceedances What we potentially need to do is link those exceedances with exceedances, for example, in changes in weather, so changes in heat, changes in rain, changes in air quality. However, some special approaches will need to be integrated in addition to our background surveillance, such as a focused enhanced surveillance for certain diseases in certain regions. So, for example, potentially we need to be specifically looking for malaria in northern countries where we shouldn't see malaria. And as is the definition of an outbreak, it can be two or more of a significant pathogen, or one of a pathogen that you don't normally see. One episode of homegrown malaria in the United Kingdom, for example, would spark a lot of concern. And the One Health approach, with the attention to the epidemiology of animal and bird infections, again linking this back to the recent SARS outbreak, the MERS outbreak and the COVID outbreak, will be needed to help anticipate and respond to outbreaks and spillover events. And again, for us as public health practitioners, it's this anticipation and response that is our bread and butter, based on robust data and surveillance. Large-scale human population migrations due to crop failures, severe flooding, storm damage, environmental deterioration may well generate vector-borne and disease outbreaks, and we need to be ready to monitor this, pick this up and respond. For example, the severe drought in East Africa led to overcrowding in the Dadaab refugee camp in Kenya, and therefore a cholera outbreak occurred at the camp, a huge task for any public health entity or body. Scenarios such as this, we fear, will increase in frequency as climate changes, such as devastating droughts, multiply the existing threats of poverty and political instability, and the inadequate infrastructure that many countries have to monitor and to respond to climate change. And again, I go back to the United Kingdom. We do not have an appropriate infrastructure to deal with summers where the temperatures routinely get up to 40 degrees. So, in conclusion, there are no effective treatments or vaccines for many infectious diseases that will be impacted by climate change. For some diseases, such as dengue, vaccines are currently under development. And it's worth recalling that diseases such as malaria, yellow fever were eradicated in the United States before availability of antibiotics and antivirals by the application of vector control measures. However, many of these programs have been reduced or eliminated because we thought we'd cleared these pathogens. For example, like we thought we'd got rid of polio. So in conclusion, as I've said, it's all about the data. Improving surveillance for emerging and established pathogens, expanding monitoring and analysis of climatic and environmental changes as they relate to infectious disease epidemiology can help us as public health professionals anticipate and respond to the infectious disease impacts of climate change. So in conclusion, climate change, we think, we believe, we fear, poses a grave and multifaceted threat to human health, and we think is now, more than any other time, a public health priority. And the time to act is now, therefore. This is thought to be one of the preeminent health emergencies of our time, and as both the direct and indirect effects of climate change increase, the medical and the public health communities will have more responsibilities to recognise and respond to changes in the epidemiology of infectious diseases, increasing attention to vectors, more intelligent surveillance for selected pathogens, integration of detailed meteorological data, so linking in with our colleagues in the Met offices and linking in with our human and animal epidemiological research colleagues, with our veterinary college, and recognition of new pathogens will require a real increase in funding and recruitment of and training of skilled personnel in this area. Clinicians at the coalface in the hospitals will need to prepare to encounter infections that they may not have previously seen in their regions, or, for example, they may need to expect organisms that they wouldn't normally see at specific seasonal times. Medical schools, residencies, fellowship programs and continuing education should offer training for these clinicians. And to that aim, just to finish with, this is a new program, and it's the only one that I've seen. This is at the University of Colorado, and they now have a specific climate and health program, and they offer an actual diploma in climate medicine. So you will come out as a diplomat in climate medicine. The UK Health Security Agency has, in December of 2022, launched its own Centre for Climate and Health Security, and your own GLIDE, the Global Institute for Disease Elimination, which is based in Abu Dhabi, have just asked for expressions of interest for the Falcon Award, and this year's Falcon Award is specifically about the climate. And anybody who's interested in this, please do go to the website, because there is a grant available for anybody who can produce what could be increased understanding of infectious diseases in the run-up to COP28. And these are really just some resources for you about climate change and health. This is the IPCC assessment report, a fact sheet on health and associated with climate change. And just to finish, these are the contributions to sustainability, because it's all right saying that, well, it's all terrible, we're all doomed and there's nothing we can do, but actually that's not correct. And there's a lot that we can do as humans, as doctors, as health professionals, not just in monitoring for the changes in climate change, but to reduce those changes. Electric cars, linking in with suppliers who send you boxes of laboratory kit, asking them to send them in recyclable boxes in one big box rather than 5 small ones, cycling to work. In the hospital that I work in, which is the picture at the bottom, we now have sensor lighting in our laboratory so that lights go off if there isn't anybody in there, so we're not wasting electricity. And I really just take you back to handing over the baton really to all of you in the public health arena and for COP26. And I say thank you very much for your time. Shukran and salam alaikum.
Thank you so much, Stephanie. We have some questions. We'll try to answer, most of these questions. I have a question regarding, can we use modeling for a prediction matter?
Can we use, what was that? Sorry.
The question is, I don't know, maybe it's incomplete. It's can we use modeling for prediction matters?
So there's an awful lot on the internet actually about modelling and development of surveillance systems. The WHO, the CDC, the United Nations are bringing these into place. But what I don't know is if there's a joined up global way that we can use modelling for predictions, because I think very much as we've seen with the COVID-19 pandemic and the vaccinations required, I don't think any one country can solve this on their own. And in my mind, it has got to be a sharing of data and a sharing of modelling and a sharing of surveillance systems globally, so that we can all predict what's going on across the world. And potentially, and in my mind, it's the public health institutes in all of the countries that need to be working together to develop these modelling systems, surveillance and monitoring systems, so that we can, share this data amongst us all.
Another question: what challenges do you observe in linking surveillance system? How do you negotiate fund resource allocation between animal health, environmental surveillance, and human health surveillance?
So it's a very, very good question, and funding is always an issue. I think the question was, how do you fund this and how do you link it? And if I can go back actually to this slide and take you back to GLIDE and the GLIDE in Abu Dhabi, and I'll just put this up so that people can read. This climate edit, it's a global initiative which aims to expand the evidence base. So it's wanting to expand the evidence base through an awards scheme. And so there'll be 10 winners announced in spring 23, following evaluation by a scientific panel. Each winner will receive a sum of $50 to undertake a formative research project over a period of 6 months in the run-up to COP28. So if anybody is wondering how you do this, I do wonder whether you could ask this question in a proposal, go to GLIDE and put this in as a proposal for the climate edit of the Falcon Awards. Unless this is already being done in the UAE, but it certainly looks like they are asking for people to get involved in the run-up to the next climate conference.
Okay. Another question: which infectious disease emerging due to climate change do you think that poses the highest risk to the UK population?
very interesting question there, and I suppose the importance of a pathogen is, can you treat it and will it kill you? And so for those pathogens such as, I don't know, Campylobacter or gastroenteric illnesses that may increase due to flooding, where they may give you a nasty gastroenteric illness, but potentially there is some antibiotics, and actually if you're not immunosuppressed, it'll be a self-limiting factor. Maybe, although we don't want to see this, we don't want to be overwhelmed with these cases, maybe they're not quite as powerful as, for example, a gram-negative bacteria in the bloodstream secondary to increasing temperature and dehydration and urosepsis, particularly in a pathogen that has developed antimicrobial resistance because of the increase in heat. Because if you think about what that will do is, firstly, what we know is sepsis kills, and sepsis kills very quickly, and antimicrobial resistance, particularly multi-drug resistant antimicrobial resistance, also kills very quickly. So I think, in my mind, and that's probably because I'm a hospital clinician that deals with sepsis and particularly patients that end up on the intensive care unit, I suppose I'm very worried about an increase in numbers of cases of sepsis, bloodstream infection secondary to pathogens associated with an increase in temperature and, of course, with antimicrobial resistance. But I wonder whether that question, you know, as in lots of things with infectious diseases, if you ask different clinicians, you'd maybe get different answers depending on what their background is.
Just to complete the question also, is there any model forecast for the its estimated disease burden
associated with climate change? So I believe that the UK Health Security Agency are working on these models. I haven't seen a complete model, I have to say, but again, if you do a Google search of infectious diseases modelling associated with climate change, there's lots of things that you can link into on the internet.
Also, you know, the question related to the first question about the model, it's completing the saying that to predict for climate change and compare to pathogen. The model asking for a prediction.
Yeah, I'm not an epidemiologist or a modeler or a mathematical modeler. I'm afraid I'm a very basic clinician, so I don't think I can answer that question. Actually, I don't know whether that. I mean, I'm assuming that you must be able to do that because all these studies must be based around modelling and linking to these predictions. But it's definitely not my my area of expertise.
Okay. What do you think specifically propose to enable increased surveillance and data collection?
What do you need to have?
Yes. Specifically propose to enable increased surveillance and data collection.
Yeah, so you need, I think that the basic is you need access to data. So in the United Kingdom, all the laboratories in hospital laboratories that detect pathogens from our patients in the hospital, in the community, all of the results feed into a laboratory information system, a LIMS. So we have a lot of data that we can pull going back years and years on what organisms we isolate. And this data from the individual LIMS systems feeds into something called the second generation surveillance system, SGSS, which feeds up to the UK Health Security Agency. So what you need is you need a good quality data system that you can pull data off from over a period of many years. So then what you would need to do, I imagine, is look at your data for exceedances. So have a background data of what is normal, what is your normal trend, and then look for exceedances in particular organisms. And then what you would need to do is link them to a list of pathogens associated with climate change. And then you would then need to link into the local meteorological office to look for changes in weather. So I think it's linking, but it's linking data, linking disease data with climate data, with pathogen data.
Thank you. The question regarding sharing your email, inshallah, we'll share your email at the end. There is another question asking Was there any study linking climate change with COVID, different mutations in different parts of the world?
Not that I know of, actually. And of course, we've only got 2 years worth of data, haven't we? So I haven't seen any data on that. I don't know whether that's been looked into. So I'm afraid I couldn't answer that.
I have another question, I think, here. Whether events are happening occasionally across various countries in which there is no systematic pattern. To what extent we can rely on a prediction of infectious disease happening systematically?
And again, I don't think I know the answer to that really. And I think the problem that we have is this is relatively not early, because people have been working on this for a very long time, but it's coming to the forefront now, isn't it? This paper was published in 2022, and I have an interest in it, and I have an interest in it because I'm a clinician in a hospital, and I want to know whether in 5-10 years time I'm going to be dealing with pathogens that I haven't previously dealt with, but I'm not a modeler, so a lot of these answers I'm afraid I can't answer.
No problem. I have another question. In the recent World Economic Forum, the two main aspects that took my attention, I mean, the question, the one who wrote the question, were the concept of 15-minute city and climate lockdown. These concepts are now getting public attention as they are proposed to improve climate change and in creating people-friendly. The question is, so what implications will this concept have on improving climate change and in addressing future pandemic like COVID-19 pandemic?
I don't think I've heard of those concepts before. Can you just repeat them?
I don't know. The question is written like this: 15-minute city. This is the first one. The other one, climate lockdown. I don't know if you can elaborate more, because these two terms.
So I'm not really aware of those terms, actually.
Oh, okay. What about the new climate lockdown policy by the UK government?
I'm afraid I'm no expert on that either. You're asking lots of very good and very difficult questions. There's an awful lot going on at the moment around this, and I'm not a politician. I'm a clinician. So.
Sure. Just to complete, like extra information, given the Oxfordshire City Council proposed climate lockdown starting from 2024. As extra information, he provided.
Oxford City Council, so that's in the south of England.
Have you seen pathogens in the UK associated with a long-range transport of desert?
Have I seen, sorry, repeat that
pathogens?
question.
Have you seen pathogens in the UK associated with long-range transport of desert dust storm?
Oh, pathogens.
Yeah.
So we have, so I'm in Manchester, which is in the northwest of England, and we have quite a big population actually from Southeast Asia and India. So we have a big Pakistani population and an Indian population, and we do see people coming back from Pakistan and from Persia and places like that. And my hospital is a tertiary centre for burns and plastics. So we do, and we have seen patients come back from that sort of desert environment with multi-drug resistant Acinetobacter, for example. We've seen that not uncommonly on our burns and plastics unit. So people who have had road traffic accidents or burn injuries in and around that very dry and arid area of sort of Pakistan and Persia, coming in with multi-drug resistant pathogens, resistant bacilli, things like that. But so those are the pathogens that I've seen, because that's the sort of area that I cover. we have seen a case of MERS, and that was an outbreak of MERS in my hospital because we have a specialist respiratory ventilatory unit, and so we took that patient for very, very specialist ventilation, and that was 2 cases of MERS about 5 years ago.
Yes, thank you so much, Dr. Stephanie. We really enjoyed your presentations. It was really informative, and thank you so much for raising a concerns. This is the first time we see the chat very full of questions related to this topic because it's a new topic. So thank you so much for your time. And unfortunately, due to the time limit, we are going to close the webinar by today. So I will let Dr. Ahmad read the closing remarks. Thank you so much.
Thank you, Dr. Azar, and thank you everybody for your very challenging questions. I've enjoyed them.
Thank you. The pleasure is ours, actually. So I really want to thank you so much again for accepting our invitations and for giving such an informative presentations, which is really a new topic. So I'm sure that our students, our network, you will receive a lot of emails from us tonight. And I would like to thank the audience for actually being with us. I know that it is after hours, but the topic is very interesting, and we thank our participants for their loyalty. If anyone have more questions to Dr. Stephanie, her email is shown in this slides, and you already filled the link in the chat to get your 1 CME category certificate 1, and look forward to our coming webinars. Keep an eye on our social media platforms on LinkedIn, Instagram, Facebook, and Twitter, and this presentation is going to be uploaded on the YouTube of Institute of Public Health CMHS, in addition to the rest of the webinars recorded. So feel free to attend it, and we thank you all and wish you all the best. And I want to thank everyone responsible for making this webinar successful, from Prof. Michael Grivna, our directors, and Dr. Mr. Ismail, Mr. Stajer, Ms. Bayan, and Mr. Amino, and of course, Dr. Stephanie for accepting, and Dr. Ahmad for moderating. And stay safe, everyone, and see you soon, inshallah. Take care. Thank you.
Thank you, Shukran.
Bye-bye. Shukran. Fun.